So soft tissue, as we all know, it's a ubiquitous thing which is present all over the body. So it is not just one organ or one type of cells that are being present, rather it is composed of varied amount of components. So it is going to be a very vast topic, but we'll try to make it as softer and as simpler as possible. So let's move ahead and see what will be the agendas for this talk. So in this session, we'll be discussing first what is a soft tissue, then we'll be discussing the grossing of a soft tissue tumor, thereafter what all microscopic features that we will see in soft tissue tumors, the type of tumors which are really immense in soft tissue, how to grade the soft tissue tumors, what are pseudosarcomatous lesions, and then finally we'll also touch upon the what's new in soft tissue tumors that have come up in the recent WHO 2020 classifications. So the first thing is, what is soft tissue? So soft tissue, as the name suggests, is anything that is soft. That means anything which has not undergone ossification or calcification is considered as soft, and it is being included in the soft tissue. So it is a mesenchymal tissue which is basically has not undergone any ossification or calcification, and it is mainly used as a supporting tissue and the filling up network which is present throughout the body. So it is composed of n number of cells, n number of things that we have already discussed in the basic histopathology course, that there are number of reticulin fibers, there are number of connective tissue fibers and the cells which constitute the soft tissue. So how do you look for a gross examination of any mass that is being resected as a soft tissue mass? So the first and the foremost thing is, if you are getting any soft tissue mass, is what is the location of the mass, whether the mass is superficial, whether it is deep, whether you are seeing any skin attached to the surface. The size of the lesion is again very important, because if you are seeing a retroperitoneal mass and if the size is more than 5 centimeters, that is most likely you are dealing with some malignant pathology. Whereas in the head and neck, the size of over 2 centimeters is also considered important. Then the next thing is whether the lesions is encapsulated or it is just well circumscribed, non-encapsulated, whether the lesion has an infiltrative margin, and then finally what is the percentage of necrosis that is being seen on the tissue. Now this necrosis percentage is being determined on the gross examination, and it is not determined on the sections that we take. So basically necrosis is to be seen on the gross section itself, and then you can confirm the area that you are seeing grossly whether it is necrosis or not. So you can take some sections from it and say whether the necrosis percentage is less than or more than 50%. Because if you're talking of a higher grade of necrosis, that means again you're talking of some malignant pathology. Now, as I said, the first is the location of the tumor. So whether the location is confined to, whether it is in the dermis, whether it is in the superficial layer of the dermis or in the superficial fat. So all these things are going to constitute your superficial tumor. Whereas once the tumor go beneath the deep layer of the fascia, that is this layer of the fascia, once it goes in the deeper regions, then it is confined, then it is known as the deeper lesions of the soft tissue. And if the lesion is deeper, then again the chances of it being a malignant are more. So basically the superficial and deep fascia are there, and if the lesion is there beneath the deeper layer of the fascia, that is the membrane of deep fascia, and if the lesion is beneath the membrane of the deep fascia, then this is what is being called as the deeper lesions. So in the cases of deeper lesions, the chances, as I said, of being malignant are more. Now, what are the specimens that you can get for the gross examination of soft tissue? So you could get biopsies, so which we will not discuss here, because there you will have to identify the tissue that is being seen. Then you could also see marginal dissections, or they are also called enucleation, where the amount of soft tissue surrounding the specimen is very less. Then you could have WLEs, that is wide local excision, where a greater amount of soft tissue is removed along with the lesional tissue. And then you could also have amputations. So this is like a marginal resection or a enucleation, where the amount of soft tissue is very less and you could just see the tumor that is being removed with the capsule. Whereas for the lesion like this, the amount of total clearance are very less because it is irregular. It has got multiple lobules. So there are chances that these are the lesions which are going to come back on the surface. Now again, there are lesions which could show enucleation. You could get a lesion with a skin eclipse, like these are the skin ellipse over the surface, and these are like WLEs. And again, you could have some marginal excisions. Then, as I said, there could be wide local excision, whereas in addition to your lesional tissue, you also see a greater amount of soft tissue that is being attached to the surface. So at times these lesions could be tagged. You could see the sutures which are being attached to the surface, and they are also labeled. So the most important thing that will go is whether the lesion is, what is the closest resected margin that is being seen on the tumor. So if you are getting a WLE like this, then it is advisable that you serially slice it. You see the area where the lesion is closest to the margin, and that is the area where you are going to slice it. So suppose for this appears to be the closest margin. So we are going to transversely slice it at about 1 centimeter interval, and then we are going to put the slide labeled as 1 to the last end slide. Then once we have arranged these slides, we are going to look for the lesion and see where the lesion is touching the most closest dissected margin. So whether the lesion is coming to the deep margin, so the area where the lesion will come to the closest to the deep margin, and the area where the lesion will come closest to the lateral margin. So these are the areas that we are going to sample on the slices. And if it is sutured, then you also know what are the different margins that you are dealing with. So this is how you're going to gross your specimen. The specimen has to be grossed once you ink it. Ideally you should ink it fresh, but it is not possible, because once you ink it fresh, the ink gets spilled over to the surface if you slice it for fixation. So what you can do is you can put your ink, let it be there for some time, and then you can slice your tissue and put cotton or gauze piece inside the tissue. The other thing that you can do is you can take the sections where whichever area is you feel is nearest to the tumor mass. Now once you have grossed your specimen, then the next thing comes your microscopy. So with this we have already discussed that the type of cells that you see in the soft tissue, they could be spindle, they could be epithelioid, round cell, pleomorphic. You could have a predominance of myxoid stroma, vascular tissue, or adipose tissue. So there could be n number of combinations of these things that you see on the soft tissue. A spindle, we all know, means that you have an elongated cell which could have either blunt end like this, or it could have tapering ends, or the ends could be different, or it could be straight, or it could show little buckling of the nuclei. So these are the different types of spindle cells that we see. Epithelioid, we see when the cells have abundant eosinophilic cytoplasm, the nuclei are also round and they look like as if these are resembling an epithelial cell. So saying that this is a sarcoma becomes difficult, because these cells resemble the epithelial cell origin and they got abundant eosinophilic cytoplasm. So this is a epithelioid variant of a spindle cell. Then round cells, these are the easiest to identify. They have got very minimal cytoplasm and they have got uniform round to oval vesicular or hypochromatic nuclei. Then finally comes the pleomorphic cells, which show bizarre nuclear pleomorphism, and it is very easy to identify again these cells on the histology. So once you see a lot of pleomorphism, that again is one of the features for malignancy, but you could also see pleomorphism in certain benign tissues, and that we will discuss later. Then finally comes your myxomatous matrix. So if it is rich in myxoma and you see a paucity of other cells, only the stellate cells, that is a scattered fibroblast present, then we call it as a myxoma, and otherwise we call it depending upon the component that is being present. So now the most important thing that is there in the soft tissue is you should be able to identify the companions. So companions are very important, and this is where the name of the soft tissue will reside in. So like you could have a companion which is rich in collagen. You have a fibroblastic cells, and in addition you have a lot amount of collagen in the tissue. So depending upon what is your companion, the tumors are being named as per the companions. Like you could have a tumor which is rich in vascular pattern along with the myxomatous stroma. You could have a fat which is there along with the vascular proliferation, a leiomyomatous proliferation again with the proliferation of blood vessels. So how you should name these specimens? So how are you going to name these soft tissue tumors? So as we know that there are over 200 types of soft tissue tumors, and many more are going to come up in the recent classification also. And it is not easier, I think, to differentiate these things. You should be able to understand what are the companions, and then you should name them accordingly. Like in this particular case, we see blood vessel proliferation, but the predominant cell is the smooth muscle cell, so that is the predominant component. So whatever is the predominant component, that is going to be the last name of the lesion. So like for this we will say that this is a angioleiomyoma, And why do we say angio? Because the blood vessels are a component of the tumor, but they're not the majority of the component of the tumor. So the predominant component has to be the last name of the lesion, and then the accompanying component has to be in the first name of the lesion. So like for this, we will call it as an angioleiomyoma, because there are few blood vessels which are tumor component, but the predominant part is the smooth muscle. Similarly, for this tumor, we have abundant amount of fat, that is the predominant component. And in addition, we could see that there is also proliferation of the blood vessels. So this is being called as angiolipoma. Angio we say first because the amount of blood vessels are less, and the predominant nature of the tumor is the lipomatous tumor. So we call it as a angiolipomyoma. Similarly, for a lesion like this, which shows a predominance of myofibroblast, and you also see some amount of vascular proliferation, so this is angiomyofibroblastoma. And then for a tumor like this, which is undergoing ossification from the fibroblast, so this is a ossifying fibroblastic tumor. So as I said, that depending upon the nature of the accompanying cells, you're going to name your soft tissue lesions, but the predominant component has to be the major lesion. Now, the patterns of spindle cells that we see in the soft tissue, we have already discussed in the basic histopathology course, and we'll just quickly rush through it. So these are the patterns that we see. So this is a herringbone pattern where they come and line themselves in the center. This is a tissue culture pattern where actually they do not form any pattern and they could be haphazardly arranged. Then we could have a whirling pattern where the cells go round and round around a central structure, that is called as whirling. Then thereafter we have a cartwheel arrangement wherein the cells go emanate from the center and they radiate outside. So this is specifically seen in cases of dermatofibrosarcoma protuberans. The most important pattern that we see in the soft tissue, and which is also very useful to identify these soft tissue tumors, is the hemangiopericytomatous pattern. And what is hemangiopericytomatous pattern? So these are these staghorn vessels that you see within the lesion, and once you see these staghorn vessels, there is a limited number of differentials that you should think for these lesions. So it could be a solitary fibrous tumors, which was previously called as hemangiopericytomas. It could be a synovial sarcoma, malignant peripheral nerve sheath tumor, then mesenchymal chondrosarcomas. These are the four main tumors that comes in the differential, and there are also a list of others like leiomyosarcoma, endometrial stromal sarcoma, and the other tumors. So, but whenever you are seeing a hemangiopericytomatous pattern, the two things that needs exclusion on the first head are the solitary fibrous tumor and a synovial sarcoma. Now, coming on to the types of tumor that we see in the soft tissue. So as I said, they could be, depending upon the components of the soft tissue, they could be adipocytic, fibroblastic, fibrohistiocytic, nerve sheath tumor, pericytic, and they could be tumors of uncertain differentiation. So these are the different tumors that we see on the soft tissue. We will discuss the major forms of these one by one. Now, for each of these types, the tumors could be benign, they could be intermediate which are locally aggressive, intermediate which are rarely metastasizing, and they could be malignant. So why is there a differentiation in each of these patterns? So the different types that we have seen, each of them could be graded according to the benign, intermediate, and malignant category. Benign means that once you have excised the tumor, it is not going to recur at the site, and then it is completely removed, that is complete treatment is done. Intermediate means that even though you have completely removed the tumor, there are chances that it could come back at the same site. So this is especially true for the desmoid fibromatosis. Now there are certain tumors which are intermediate category, like plexiform fibrohistiocytic tumors, which if after excision they could come back at a distant metastasis. So these are rarely metastasizing. They usually do not metastasize, but rarely they can also show metastasis. And then finally the malignant category, which means that even if you are removing the tumor, you may have mets elsewhere in the body even at the time of resection. So they have a high propensity of metastasis. So this is how we are going to divide different soft tissue tumors into the different grades, and this is true for each type of tumor that we will discuss. So this is the latest WHO 2020 classification for the soft tissues, and as you can see here, there are n number of tumors which have entered into this classification, and there are even more which have been coming up every day based on the recent genetic and molecular classification. Now there are few ones which have recently included and which needs a special mention are, the first is the atypical lipomatous tumor is an intermediate category. So this we will discuss how an atypical lipomatous tumor is of intermediate category. The second is solitary fibrous tumor could be anything. So when you have a solitary fibrous tumor and it is being resected, and on histology you are seeing the features of solitary fibrous tumor, so that can behave in a benign fashion, that can behave in an intermediate fashion, and that can also behave in a malignant fashion. Now next is the epithelioid hemangioendotheliomas. They are now considered malignant, apart from all other hemangioendotheliomas which are still considered as of intermediate category. So if you are seeing hemangioendothelioma which is composed of epithelioid cell, that means you are dealing with a malignant tumor, and that is as per the recent 2020 WHO classification. So we'll go on to each of these tumors one by one. So first is the adipocytic tumor. As I said, they are predominantly composed of fat, and we all know what a fat is, which has got a nucleus with the periphery and a large central nuclear vacuole. So that is a white fat that we usually see in the body. And if this fat, depending upon the component, adjoining component that is being present, they could be classified as angiolipoma, chondrolipoma, myxolipomas. So whatever component is present in addition to the fat, that is they are being named as per the component that is being present. So they could have different combinations depending upon the adjoining component that is to be present. I have specifically put this angiolipoma here because there are only very few soft tissue lesions which are really painful to the body, and angiolipoma is one of them. So you should remember that most of the soft tissue tumor, they are seen as a painless mass within the body, and their simple excision is curative, but there are few of them which are really painful, and one of them is angiolipoma and another one is angioleiomyoma. So these are the few tumors which cause pain to the body, and then neurofibroma, as we all know. So these are the tumors which are painful to the body. Now, the two important type of lipomas that need a specific mention here are the spindle cell lipomas and the pleomorphic lipomas. In the spindle cell lipomas, both these tumors, they have a predilection for the neck and the shoulder region. So this is the area where you will usually see them. The spindle cell lipomas will have a component of spindle cells along with the fat cells, whereas in pleomorphic lipoma, they look more bizarre, but the cells, if you could make out, they have got a floret cell kind of a rearrangement. Floret means because the nuclei will be at the periphery and they will appear as if there is a flower in this giant cell. So these are classical for a pleomorphic lipoma, and in addition to these floret cells, they will also be having a component of these spindle cells. So if in a spindle cell lipoma you are seeing floret cells, that means you are dealing with a pleomorphic lipoma, and both of these lipomas belong to the benign category. Now, there is another type of tumor which is made up of brown fat, and that is known as hibernoma, which is also seen in the young adults. And in this hibernoma, instead of a single univacule that is seen in the white fat cells, you see multiple vacuoles within the cytoplasm. So if you are seeing multiple vacuoles within the fat cell, that means you are dealing with the brown fat, and this kind of a nature of the lipoma is called as hibernoma. Then moving on to the malignant category, we have liposarcomas or the atypical lipomatous tumors. So these atypical lipomatous tumors and liposarcomas, they are being differentiated by the location of the tumor. So suppose you have you are seeing some atypia in a lipomatous tumor which is present on the extremities where the size of the lesion is less, then they are being called as atypical lipomatous tumor. These are considered as tumor of intermediate category, and you could occasionally also see lipoblast in them. But even if these lipoblasts are not found and you are seeing atypia in any of the adipocytes or in the stromal cells, then you are going to call them as a atypical lipomatous tumor. The similar tumor, when it occurs in the retroperitoneum, then we call it as a well differentiated liposarcoma, which now becomes a malignant tumor. So there is a very thin demarcation between an atypical lipomatous tumor and a well differentiated liposarcoma. Atypical lipomatous tumors you will use when they are coming out from an area where they could be easily resected, whereas well differentiated liposarcomas are generally seen in the retroperitoneum where they are of large size, and they could recur or it is difficult to resect them. But at times they are also used interchangeably. So what are the criteria for a liposarcoma? When are you going to call it as a liposarcoma? So the first thing that you should look for is the atypia, and where this atypia should be. So this atypia should be either in the stromal cells, like you could see here. So there is a bizarre stromal cell that is being present here, or it could be present within the adipocyte. So in a normal fat cell, you will hardly see the nuclei because the nuclei is being pushed to the periphery. But if you are seeing prominent nucleoli in most of the adipocytes, then that means those adipocytes are showing significant atypia. So if the atypia is seen either in the fat cells or in the stromal cells, so in either of them, so it is not necessary that you should see the atypia only in the fat cells. If it is seen either in the stromal cells or in the fat cells, and then in addition you could find some lipoblast accompanying them, then you call it as a liposarcoma. But the presence of lipoblast is not required for making a diagnosis of atypical lipomatous tumor or a well differentiated liposarcoma. And how does the lipoblast look like? So this is a beautiful picture that is being showing a lipoblast. So these are multiple fat vacuoles which are indenting the nucleus, and you could see the nuclear is scalloping. You could see indentation of the nuclei here, and this is again another lipoblast showing a large vacuole which is indenting upon to the nuclei. So if occasionally you could also find these lipoblast, and once you find these lipoblast, the diagnosis of liposarcoma becomes easy. But it is not necessary that you find them in all the cases, and if only by seeing the atypia also you can say that this is a liposarcoma. Then there is another variant which is a myxoid liposarcoma, in which in addition to these atypia you also see a predominant component of myxoid matrix which is being accompanied by vascular proliferation. So if you are seeing florid vascular proliferation, there is a rich network of capillaries within a myxomatous stroma, and then adjoining it you are also finding some atypical lipomatous lesion at time, then you call it as a myxoid liposarcoma. But sometimes in the myxoid liposarcoma, it is composed of predominantly round cells, which is called as round cell liposarcoma, which carries even a bad prognosis as opposed to that of myxoid liposarcoma. Now, there is another variant of liposarcoma, which is called as dedifferentiated liposarcoma. And there have been some changes in this dedifferentiated liposarcoma in the new WHO classification also that we will discuss. Now, if you could see here, this is a liposarcoma, that this is a fat tumor. It is relatively well circumscribed, and this is all an atypical lipomatous tumor, and suddenly it has undergone transformation into a dedifferentiated liposarcoma. So, what is dedifferentiation? That means an atypical lipomatous tumor has undergone abrupt transition into a high-grade sarcoma. So there is an abrupt transition from these soft fat tissue areas into a differentiated area where you see that there is definitely a sarcomatous appearance. Previously, this dedifferentiated sarcomatous areas, they were not graded, and they were just taken as dedifferentiated liposarcomas. But now the recent WHO says that you should also grade these dedifferentiated areas as per the FNC LCC grade, and then based on the grades you can also determine their prognosis. So that is a dedifferentiated liposarcoma. And as I said, sometimes in myxoid liposarcomas you'd see a predominance of ovoid and the round cells, which is again of a poorer prognosis if you see a predominance of round cells. Now, the next line of differentiation is the smooth muscle tumor. So, smooth muscle tumors, as we all know, they have got a spindle-shaped nuclei with the blunt end. So, these are the blunt end of the smooth muscle, and this is how we are going to identify the smooth muscle cells. Now, the most important thing whenever we are seeing any spindle cell is the presence of these eosinophilic cytoplasm. So, the smooth muscle cell will have got a pinkish or a pinkish cytoplasm, and that is how you are going to differentiate these from the myofibroblast or the fibroblast, which have got a bluish cytoplasm or a amphiphilic cytoplasm. So fibroblasts will have a more bluish cytoplasm, whereas your spindle cells will have got a eosinophilic cytoplasm. The nucleus of the cell will have a blunt end as if they were that of a cigar shape. So any tumor which is like this, so this is your whorled appearance, since they are composed of dense network of spindle cells, they have got a whitish whorled appearance on cut surface, and this is a renal leiomyoma where you see that there is a diffuse proliferation of the spindle cells within the leiomyomatous area. Now, these are usually accompanied by foci of calcification and hyalinization around the vessel wall that we could see here, and at times they could also show vacuoles around these smooth muscle cells. So this is just an artifact of cutting these cells. So there could be vacuolation around these cells, but actually that is not a vacuolation, and that is just a sectioning artifact. Now, this we had already discussed that this is a leiomyoma where you see numerous smooth muscle fibers which are seen around the blood vessels. So, when they show whirling around the blood vessels and you see a compressed lumen in the centers, these are being called as angioleiomyomas. Like you could see a blood vessel lumen here, and then you see the whirling of the smooth muscle cell around the blood vessels, and there are also painful lesions to be there, and once resected, they are cured. So this is again showing a whirling of the leiomyomatous cells around the blood vessel. Now, the malignant category, in the malignant category of the smooth muscle cell, we have got leiomyosarcomas, and the leiomyosarcomas of the soft tissue, they are little distinct from those what we saw in the uterus or in the other female genital tract. So, in the leiomyosarcomas, you should see areas of mitosis as well as atypia. So, they, both these things should be present, and in addition, you could also see areas of coagulative necrosis. So, if it is present, this is a high predictor of being malignant in the leiomyosarcomas. So in the leiomyosarcomas, there should be definite atypia of these smooth muscle cells, and in addition, there should be a predominance of mitotic figures, which should be in the tune of more than 10 per 10 high power field. So because this is important, because there are variants of leiomyomas, which are like mitotically active leiomyomas, there are cellular leiomyomas, there are leiomyomas with bizarre nuclei. But in most of them, you could find either one of the features, but they generally do not show both the features of the atypia. Like in the mitotically active leiomyomas, you do see increased rate of mitosis, but that will not show you significant atypia of the leiomyomatous cells. Whereas in the leiomyomas with the bizarre cells, you see that there are certain bizarre nuclei, but again you fail to see a significant amount of mitotic figure there. So if you have both mitotic figures and significant atypia, especially from a soft tissue lesion of the extremities, you should think of a leiomyosarcomas, and getting an immunomarkers will help you confirm this the presence of this tumor. So any of the immunomarkers, that is either SMA or desmin or keldesmon, any of these markers you can get it done, and once any of these markers are positive, you know that that is a leiomyosarcoma. So it is not, ideally you should have more than 2 markers, but even the presence of a single marker is sufficient to call them as a leiomyosarcoma. Now, these are the areas of geographic necrosis that we see in cases of sarcomas. And if you see these areas of geographic necrosis, then also you are really sure that this is a sarcoma that we are dealing with. And at times you do see that there is a coagulative necrosis of the cells that is being present there. And if you see coagulative necrosis in a leiomyomatous lesion, then again it is a strong predictor that this is likely a malignant neoplasm. So if you are seeing coagulative necrosis, again you could be sure that this is a leiomyosarcoma. Now, the next in the tune is a skeletal muscle tumors, which show rhabdomyomatous differentiation. And the markers that you can do for the confirmation is MyoD1, myogenin, and desmin will also be positive in a skeletal muscle tumor. These skeletal muscle tumors, they could be of different shapes. And the most important feature of these skeletal muscle tumors is that most of these tumors are seen in a younger age group, as opposed to the other sarcomas which occur in the adulthood or of the uncertain origin that we will discuss later. And these sarcomas of the skeletal muscle differentiation, they show these eosinophilic, abundant eosinophilic cytoplasm. So they have got these cells which are called as the rhabdomyoblast, and they have got an eccentric nuclei and a eosinophilic cytoplasm. And these are the classical rhabdomyoblasts that we see in cases of rhabdomyosarcoma. The presence of these rhabdoid cells will tell you that this is a rhabdoid nature of the tumor, and you can confirm this by doing a immunostains for the rhabdoid markers. Then there are variants of rhabdomyosarcomas, that is the pleomorphic rhabdomyosarcomas, which wherein you see that there are large bizarre cells, which in addition to these the rhabdoid cells and the pleomorphic cells that are being present, and many of these will show these striations that is being present within the pleomorphic cells. That will also tell you that this is an indicator towards a skeletal muscle differentiation, and again you can go for your markers. Now another variant of rhabdomyosarcoma is an alveolar rhabdomyosarcoma, which is called alveolar because it shows a pattern that is reminiscent to that of alveoli of the lung. So the cells are being arranged at the periphery, and you have got a central lumen-like area. So this kind of an arrangement is called an alveolar arrangement, and this is seen in cases of alveolar rhabdomyosarcoma. So now the next in the nature are the neural tumors, which are the tumors which arise from the nerves, and they are characterized by presence of spindle cells which show wavy or buckling nuclei. Now, these neural tumors, the commonest one are the neurofibromas and the neurilemomas or schwannomas. The neurofibromas, as we could see here, they are composed of each and every component of the nerve. So, all the components of the nerve, they proliferate in a neurofibroma. They're really not encapsulated so well as we see for a case of schwannomas. So, schwannomas are relatively well encapsulated. They're composed of predominantly the proliferation of Schwann cells, as we could see here. So, this is a nerve fiber, and these are the Schwann cells, and here you could see a proliferation of Schwann cells. So they could be resected out separately and easily from the nerve fibers with which it is being attached. So they could be easily resected out from here. Whereas for a neurofibroma, since they are composed of all the component of the nerve and they are seen in between the nerve, you need to transect the nerve also in addition to this neurofibroma. So there are classical patterns that on histology which will help you to differentiate schwannoma from a neurofibroma. And what are those? Is it is that like this is a case of a traumatic neuroma in which you see multiple nerves which have proliferated along with the bundles of collagen fibers. So when you see multiple nerve bundle proliferation along with collagenous tissue, that is seen secondary to any transaction of the nerve, and that is being called as traumatic neuroma. And this is a case of plexiform schwannoma. And how does a plexiform word and what does a plexiform word means? Plexiform means when you have multiple nodules instead of one nodule. So if you have multinodular appearance of a tumor, then this is what is being called as plexiform schwannoma, as in this case, or they could also be plexiform neurofibroma. So this is an image from a neurofibroma, and as you can see here, most of these nuclei, they're distinct from the cells that we have seen in the smooth muscle differentiation, which have got a blunt end nuclei and an eosinophilic cytoplasm. Whereas if you see here, they do not form really any pattern, they're diffusely scattered, and they show a classical buckling or indentation of the nuclei. They've got tapered ends, and they've got tapered ends and little cytoplasm that we see here. So this is classical for that of a neurofibroma. Now, this kind of a picture we usually see in a schwannoma, and what is these known as are the verrucate bodies. So normally in a schwannoma, we have hypercellular and hypocellular areas. So there are two kinds of areas that is usually seen, and once you see these verrucate bodies, you are really sure that this is a schwannoma. And how do you are going to write in the report? You will just say that this is a spindle cell neoplasm compatible with a schwannoma. If you want, you can get your immunomarkers for S100 to confirm these findings. So this is called nuclear palisading, that we see the nuclei are arranged one beneath the other, and they leave the cytoplasm at one end, and these are also called verrucate bodies, or these are also called the cellular areas of the schwannoma. Now there is a variant of schwannoma which is called cellular schwannoma, in which which is composed of mainly of the type A area or the verrucate bodies, and in which the hypocellular areas are minimal. Whereas in a normal schwannoma, there is an admixture of hypocellular and hypercellular areas. Now, again, there is a variation in this, which is called as ancient schwannoma, in which it's again an encapsulated lesion, but there are also areas of hemorrhage and necrosis. So what is classical for an ancient schwannoma is that it is worrisome because many of these tumors will look very bizarre. They could have increased mitosis, and they are also presence of atypical nuclei. But they generally shows this classical hyalinization of the vessel wall, as we could see here. There could be some verrucate bodies somewhere within the cell, and they could give you a feel that this is a neural tumor that you're dealing with. If you do an S100 immunostain, you can confirm your findings. So that was about an ancient schwannoma. And how do you differentiate it? By MPNST, that is malignant peripheral nerve sheath tumor. So in malignant peripheral nerve sheath tumor, they tend to be more cellular, and there is a new marker that has come up for MPNST. They are generally less positive for S100, whereas whereas for the schwannomas, you see a diffuse positivity for S100 nuclear and cytoplasmic staining that we see for S100, and there is a new marker that has come up for MPNST, which we will be discussing subsequently. Now, this is again a neural tumor which shows you abundant cytoplasm, which is eosinophilic and granular, as is well defined on histology. Now, this kind of a tumor can occur anywhere in the body. So these are one type of tumors which can present from tongue to breast to any soft tissue of the body, and they could again be benign, intermediate, or malignant. These are composed of these cells with abundant eosinophilic granular cytoplasm, and they're thought to be of neuroectodermal origin. If you do an S100 stain, they will also be diffusely positive, but they are not to be confused with the neural tumors that we have seen earlier, because those neural tumors, they show a wavy form nuclei or a spindle shaped nuclei, which is not being seen in this case. Then we have a variant of, like as I said, the accompanying cell, you call them differently. So in this case, we have got these neural cells, and in addition, we also have got these cells which have got abundant cytoplasm and an eccentric nuclei. So these are all the ganglion cells. They are not granular, as we have seen in the granular cell tumor, which is composed exclusively of the granular cells. But here you see that they are composed of scattered ganglion cells together with these nerve bundles. And since the nerve bundles are the predominant component, we are going to call them as a ganglioneuroma. So these are the feature of the ganglioneuroma. They're also well encapsulated at one sex side. Their chances of recurrence are minimal. So now the next thing is a MPNST, that is malignant peripheral nerve sheath tumor. They resemble a spindle cell neoplasm. They could have herringbone pattern and they're very cellular. One of the classical features that have been described in MPNST is a shredded carrot-like pattern of the collagen fibers. So you see haphazard arrangement of collagen fibers. So if it is present, it is useful, but even if it is not present and you're seeing a cellular neoplasm with pleomorphism, bizarre nuclei and atypia, then this is what you should do a neural marker to confirm that this is a malignant peripheral nerve sheath tumor or not. Now, the next in the category are the fibroblastic tumors, that is the tumors which show fibroblastic differentiation. And as I said, if you have a component like you could see here, there is abundant fibroblastic proliferation together with the collagenous stroma. So this is a fibroma, that is which is composed of fibrocytes and collagenous tissue, and it is again a benign tumor usually seen on the extremities. Then we have got the fibroblastic tumors, which are composed of fibroblastic differentiation, but they're usually not encapsulated and they infiltrate the surrounding tissue in different patterns. So it is difficult to excise these tumors, and it is also very important to know these tumors because these are the tumors that are going to recur. They're very common and you frequently see them in the practice. So these are called fibromatosis, and they could be of superficial type, and abdominal or extra abdominal fibromatosis is what is being described as. Abdominal fibromatosis, also called desmoid type fibromatosis, which are usually seen subcutaneous tissue in the abdominal region, and they generally have infiltrating areas into the surrounding structures, and so they tend to recur once you excise them because there is generally incomplete excision of these tumors, and they are generally not positive for any marker apart from beta catenin, which shows a nuclear positivity. Now, this is a case of mesenteric fibromatosis. So here you could see that this is a nodule which are seen in the mesentery, and these are the fibrocytic proliferation, and you could see here that this is a muscle tissue and they are seen in emanating from the muscle fibers. So this is again an irregular fibrocytic proliferation, and these are also not capsulated, that like we could see for other benign fibrocytic lesions. So as there is no boundary to these cells, they are going to recur subsequently, and so it is important to identify these lesions. Now, this is a classical pattern that we have discussed in the basic histopathology course also, and this is being called as a herringbone pattern, wherein you see parallel fascicles of the spindle fibers which come and merge in the center, and this is classical for that of a fibrosarcoma. There is no definite marker that you can do, and it is a diagnosis of exclusion. You have to see the histology, which is showing a herringbone pattern, and then once all your markers, that is the differentiation markers for SMA, Desmin, and your rhabdomyoblastic markers, neural markers, they are negative, then you know that you are dealing with a fibrosarcoma. So this is a fibrous histiocytoma in which you see that there is a proliferation. The overlying epithelium show significant epithelial hyperplasia, which is usually seen in cases of benign fibrous histiocytoma, whereas in cases of dermatofibrosarcoma protuberans, again a very common tumor to be seen in the practice, and these are the tumors that are going to come back like every 5 years or 7 years. There are chances of recurrence of DFSP. You can give radiotherapy also for them. They usually show a cartwheel, they usually show this cartwheel kind of an arrangement, which is classical for a DFSP. And these DFSPs and fibrous histiocytomas, they are CD34 positive. That is one marker that will help you to tell that this is a dermatofibrosarcoma protuberance. They have got infiltrative margins at the edges, as we have seen for the fibromatosis also. And the epithelium in cases of DFSP is going to be thinned out, atrophic, as opposed to benign fibrous histiocytomas, which show a proliferative epithelium. Now, the most important tumor in this group, and which should be differentiated from other tumors, is a solitary fibrous tumor. So what kind of a pattern are we seeing here? So if you look here carefully, you are seeing multiple staghorn kind of a vessel, and this is the pattern that is being called as a hemangiopericytomatous pattern. And based on this pattern, that these tumors were previously known as hemangiopericytomas, which is now an obsolete term. So we do not use hemangiopericytomas these days. We just say that this is a solitary fibrous tumor. It is very, very important to identify these tumors and to differentiate them from other tumors. So if you have a resection specimen in hand, you could identify these hemangiopericytomatous patterns. And otherwise, if in a biopsy tissue, you are only left with the immunomarkers, because there is no at times you will not see these hemangiopericytomatous pattern that carefully. So there is a combination of markers that is going to tell you that this is a solitary fibrous tumor. So these tumors are usually CD34 positive. They are positive for BCL2 and CD99. So if you are seeing a combination of all these three stains, that is CD34, CD99 and BCL2, that is going to tell you that you are dealing with a solitary fibrous tumor. Now there is a new marker that has come up for the solitary fibrous tumor identification, and that is STAT6 nuclear marker. So that is a nuclear immunostain, and once you put STAT6, you know that you are dealing with a solitary fibrous tumor. It is very important to differentiate these tumors from a synovial sarcomas, which could have monophasic or biphasic appearance and which could also show a similar hemangiopericytomatous patterns. So these are one of the few tumors that can be identified on histology and on histology itself, and these are the tumors wherein you have specific chemotherapy, especially when you're talking of a synovial sarcoma. So these are the different like solitary fibrous tumors on a biopsy tissue. It is very difficult to identify hemangiopericytomatous pattern on the biopsy tissue, and you end up doing a panel of immunostains for all your spindle cells, and then if they are positive for CD34, CD99 and BCL2, then you start thinking of a solitary fibrous tumor. And if you have STAT6 in hand, you can get a nuclear stain for STAT6, which is positive in solitary fibrous tumors. Now, vascular tumors, we'll just quickly rush through them because we all know about vascular tumors. They could be hemangiomas, and then they could be intermediate tumors, which are hemangioendotheliomas. And the hemangiomas, we all know, will show a lobular proliferation of the capillary vessels. This is a lobular hemangioma in which you see proliferation of the blood vessels. If you are not able to typify the different types of hemangiomas, you can just say on histology that these are vasoformative lesions in which they show patterns similar to that of a hemangioma. But if you see the cells which are proliferating in addition to the vessels and they are surrounding the vessels, so these are epithelioid like cells which have got abundant cytoplasm, like which are more beautifully seen here. So these are all hemangioendotheliomas, and one of the features of hemangioendotheliomas is that these cells will also show presence of intracytoplasmic RBCs. So if you are finding intracytoplasmic RBCs, that means these are the cells which are going to form a luminal component later, and these are the endothelial cells. You can do a CD31 and CD34 immunostains in which CD31 is more sensitive and specific for diagnosing a vascular proliferation. So you have benign tumors which are hemangiomas, intermediate tumors which are hemangioendotheliomas, and then a variant of hemangioendothelioma, that is epithelioid hemangioendotheliomas, as I discussed, is now included in the malignant category. Then you have a last category of tumor wherein the blood vessels, the lumen that you have that's seen lining the vessels, they are showing significant pleomorphism and they come and abrupt into the lumen, and these are the cases of angiosarcomas. Most of these angiosarcomas are seen after a follow-up of radiotherapy. So they are radiation-induced angiosarcomas or chemotherapy-induced angiosarcomas, and they're usually seen after mastectomies, after the radiation therapy, or in the skin after a radiation dose. And how do you identify them? You see blood vessels which are lined by cells which protrude into the lumen and which show significant pleomorphisms. So this is again CD31 and 34 positive, but it is not the marker that is going to tell you that this is an angiosarcoma. It is the histology that will tell you that this is an angiosarcoma and this is not a hemangioendothelioma or a hemangioma. Now, as I said, this epithelioid hemangioendothelioma, which is now also included in the malignant category. So in this, you have got cells which have abundant eosinophilic cytoplasm. You do your markers, you do your CD31 stain, and they will be beautifully CD31 positive. So they're usually seen as multiple nodules within the liver or also within the lung, and they're also occurring in the soft tissue. Now, finally, we'll come to the tumors of uncertain differentiation. And these are the few tumors, we'll quickly touch upon them. The tumors of uncertain differentiation: synovial sarcoma, epithelioid sarcomas, alveolo-soft part sarcoma, clear cell sarcoma, and myxoid mesenchymal chondrosarcoma. Now, the important thing to remember from these tumors of uncertain differentiation is that they do not show one specific marker for a different lineage that we have seen for the smooth muscle, skeletal muscle, neural tumors. They do not show expression of those markers. Secondly, all these tumors of uncertain differentiation, they are common in the younger population. So these are all sarcomas. They occur in a younger age group, that is, you have adults of the age group of 20 to 40, and then most of these sarcomas are seen there. You have specific chemotherapy for synovial sarcoma, so it is very, very important to identify these synovial sarcomas. Then there is another tumor which is called epithelioid sarcomas, which are common on the forearms. Synovial sarcomas, as the name suggests, they do not originate from the synovium, but since they are known to occur near the knee joint, so the name was initially given as synovial sarcomas, but actually they have nothing to do with the synovium, and just that they originate from these knee joint. Epithelioid sarcomas common in the young males from the wrist, and if you have not enough experience with them, if you see them for the first time, you could think that you are dealing with a tubercular granuloma, because they show a lot of caseation and they show a predominance of epithelioid cell. Then we have alveolar soft part sarcomas, which show a pattern which is similar to what we have seen in alveolar rhabdomyosarcomas, but those alveolar rhabdomyosarcomas, they occur in a still younger age group. Alveolar soft part sarcomas, which occur in the relatively older age group. Then we have clear cell sarcomas of the soft tissue, which occurs on the feet. So one in the feet and one in the wrist. So these two tumors are specific of uncertain differentiation. Epithelioid sarcomas, they have a classical predilection for the wrist joint and the forearm. Clear cell sarcomas, they're usually seen in the feet and they're counterpart of the melanoma. So these are HMB45 positive. And if you have a sarcoma which is coming from the feet, which is showing you predominance of clear cell, get an HMB45 or Soxtin done, and then you know that this is actually a melanoma. And the next one is the myxoid chondrosarcoma. So this is a case of a synovial sarcoma, and in this we could again see that hemangiopericytomatous pattern that we have seen for the solitary fibrous tumor. So how are you going to differentiate them? They show dual differentiation. So it is not an absolute thing that you see for all synovial sarcomas, but if present, it is very useful. They could have a monophasic appearance or biphasic appearance. Monophasic we say when there is a predominance of spindle cell or predominance of epithelial cells. So if you have a tumor which is showing spindle cell proliferation as well as areas which are showing glandular arrangement, then you are thinking of a synovial sarcoma, and these are the only sarcomas which show biphasic type of a differentiation. If you do immunostains, they are negative for CD34, which is classical for synovial sarcoma, and there are new markers which have come up which we will also discuss. Now, as I said, for the epithelioid sarcomas, they look like a tubercular granuloma, but the cells which are surrounding these caseous areas of necrosis, and if you are getting a tissue from the near to the wrist joint and there is abundant necrosis and the surrounding cells, they look little more epithelioid and they are showing significant pleomorphism and mitosis, then you should start think of on the lines of epithelioid sarcoma. Then the last in the categories are the undifferentiated round cell tumors, and much has been done on these round cell tumors. Initially, we had only Ewing sarcoma or the peanut category, and they are composed of these small round cells with the areas of necrosis, but now there is also a spectrum of other round cells which could be identified with the help of immunostains. So now we have discussed about the sarcomas and the soft tissue tumors. There are few things that we would like to discuss here. First is when we are talking of soft tissue tumors. So soft tissue tumors, over 80% are benign tumors. Then among the intermediate categories, the commonest one to be seen in the practice are the fibromatosis and the dermatofibrosarcoma protuberans. See, these are the two which are the commonest ones, and DFSPs will be coming from the skin lesions, whereas the fibromatosis will be coming from the abdominal or the extra abdominal organs. Now that is the plantar or the palmar fibromatosis. How do you differentiate fibromatosis from DFSP? First is their location. The DFSPs are common on the skin. The fibromatosis are common in the abdominal tissue. Second is the immunostain. The DFSPs are positive for CD34, whereas your fibromatosis will not show positivity for any of the markers except for the nuclear beta-catenin, which is present diffusely within the fibromatosis areas. Now, less than 20% of the tumors, here we would say that around 20 to 30% of the tumors will be the sarcomas that we see in the practice. And most of these sarcomas, they are usually coming from the extremities, over 80% of them, and some of them will also come from the retroperitoneum, especially the liposarcomas. They are mostly seen in the older age group. They arise from the deep tissue. So most superficial tumors are benign, and most deep tissues, as I said, we should think of sarcomas. They arise de novo, and their origin from the previous pre-existing tumor is very less. Most of them will go to the lung. So lung is the commonest site of predilection where they will go for metastasis. What are the exceptions? The exceptions are the sarcomas of uncertain differentiation that we have discussed, like synovial sarcomas, epithelioid sarcomas, clear cell sarcomas, alveolar soft part sarcomas. They are usually seen in the adult age group. So these are the tumors which will come to you in the age group of 20 to 40, and then this is the age group where you should think of sarcomas of uncertain differentiation, and you should get your immunomarkers done, and they have got a classical site of predilection. So you should be aware of what is the topography and from where these lesions are coming to you. The rhabdomyosarcomas are one type of sarcomas which are usually seen around 10 years of age or even less than 10 years of age. So, and these are the tumors, these rhabdomyosarcomas, they also have predilection for the head and neck. So these are the orbital rhabdomyosarcomas and head and neck rhabdomyosarcomas. They are very common, and these are usually seen in the childhood age group, so that should be remembered. Most of them are deep. So most sarcomas are deep, but there are few which occurs in the superficial location, and those are epithelioid sarcomas and myxofibrosarcomas. Then there are certain sarcomas which show lymph node metastasis like epithelioid sarcomas, synovial rhabdomyosarcomas, clear cell and angiosarcomas. So as we have said that most sarcomas will go to lung, but the sarcomas of uncertain differentiation, they have a predilection for lymph node metastasis. How do you grade a soft tissue tumor? So if you have got a soft tissue sarcoma, how you're going to grade it? So the first question is, shall I grade the intermediate grade tumors also? Like, shall I grade DFSP? Shall I grade fibromatosis? Yes, you should grade, and there are differentiation categories that are being given in the sarcomatous group, and you should grade these tumors also depending upon the necrosis, mitosis, and the differentiation grade. Now, the three things that are to be looked for is the necrosis, mitosis, and differentiation. The differentiation table is being given in the CAP protocols for the soft tissue, and you can take those differentiation grades as 1, 2, or 3 depending upon what type of tumor it is. The necrosis is seen grossly on the tumor and not on the microscopic slide. So on the gross examination, you will identify whether the percentage of necrosis is less than or more than 50%, and then you are going to count your mitotic rate per 10 high power field. And now they have changed from per 10 high power field to per millimeter square in the new recent WHO classification. So just a word about the pseudosarcomatous lesions. These are again, these mimic sarcomas because they show hypercellularity, they also show mitosis, but these are actually not sarcomas. And the most important thing to remember is these are usually seen in the younger age group from the superficial lesions, and they are usually seen as a subcutaneous nodule, so they are not deeply located. So the commonest one to see is the nodular fasciitis, proliferative myositis, and ischemic fasciitis. So these are just few of the pictures of these cases. So nodular fasciitis will show you hypercellular stroma. Classical presence, and which will helpful, is the presence of these extravasated RBCs. So and their presence of also inflammatory cells. Another important thing for a nodular fasciitis, myositis, or proliferative fasciitis is that most of these patients will show you a history of trauma. So they got hit somewhere and then subsequently they developed a nodule. The history will be short, so the history is not going to be very long that they are being present for so many years, and immediately there is a rapid growth. So within 2 or 3 months there is a rapid growth of subcutaneous nodule which has popped up, usually seen in the younger age group and not in the older age group. And if you're seeing a hypercellular stroma, extravasated RBCs, presence of inflammatory cells from a subcutaneous lesion in the wrist or or elsewhere, then you should think of a nodular fasciitis. In a case of nodular fasciitis, if you see presence of ganglion cells, you call it as a proliferative fasciitis. And if this proliferative fasciitis infiltrates the muscle, and this is classically called as checkerboard pattern, where you see dark muscles and light of these myofibroblasts and fibroblasts, then this is known as proliferative myositis. So nodular fasciitis with the ganglion cells is a proliferative myositis, a proliferative fasciitis, and a proliferative fasciitis infiltrating the muscle is a proliferative myositis. So these are the some pseudosarcomatous lesions that we will encounter in our practice. It is important to differentiate them because they are at times cellular, they show mitosis also. But the most important thing is again the location, they are superficially located. And secondly, the presence of a younger age group and the and history of trauma if present, then it is also very useful. Now, the last thing, coming to the last topic of this talk. So what's new in 2020 soft tissue tumor? Because the 2020 soft tissue lesions has just come up. So I thought we'll just quickly summarize. So what is new that has come up in the 2020? And this could be a question for the PGs who are appearing for their exam. So first thing is there are new soft tissue tumors which are defined. So some of the tumors have now recently come up in the 2020 classification, which were not previously there. And the one of them is the atypical spindle cell pleomorphic lipomatous tumor. So if atypical lipomatous tumors, that is your well differentiated liposarcomas, if it has spindle cells and pleomorphic cells also, you call it atypical spindle cell pleomorphic lipomatous tumor. And these tumors are separated from the atypical lipomatous fibrous tumor because they do not show MDM2 methylation. So MDM2 positivity will not be seen in cases of atypical spindle cell pleomorphic lipomatous tumor. Then there is a variant which is myxoid pleomorphic liposarcoma. So you have pleomorphic areas, you have myxomatous areas, and then you call it as a myxoid pleomorphic liposarcoma. There are few entities which have been described in the fibroblastic tumor category, that is angiofibroma, mutation associated fibroblastic tumor, superficial CD34 positive fibroblastic tumor. So these are the few tumors which have been described in the fibroblastic categories. In the vascular tumors, epithelioid hemangioendotheliomas, which are now considered malignant, they have been shown to show this TFE3 mutation, and this is also being utilized as an immunomarker to diagnose these epithelioid hemangioendotheliomas. In the smooth muscle tumors, we have inflammatory leiomyosarcomas. If you see a leiosarcoma with the predominance of inflammatory cells, we call it now as a inflammatory leiomyosarcoma, and it is now a distinct entity which is different from the leiomyosarcomas. Then there are tumors of uncertain differentiation, and the most important change that has come up is in the tumors of small round cell tumors. So previously we have only the Ewing's category, that is Ewing sarcomas and peanut category, and the tumors which do not show EWS mutation, we used to call them as a waste basket Ewings. Now within that waste basket, we have three tumors which are now being reclassified. One is your CIC rearranged sarcoma, B-cord genetic alteration sarcomas, and round cell sarcoma with EWSR1 non-RTS fusion genes. So these are the genetic alterations, and these are being described in the small round cell tumors, and they are found to be a distinct type of tumors apart from the Ewing sarcoma. So there is a major change in the small round cell tumor category in the soft tissue tumors. Now, what are the new markers that have been described and which can aid you in the diagnosis of these tumors is, like as I said, for the solitary fibrous tumor, STAT6. So STAT6 is showing you NAP2 and STAT6 fusion mutation, and this is the marker that is also available as a IHC marker. It shows nuclear positivity in cases of solitary fibrous tumor. Epithelioid hemangioma, FOSB is the IHC marker. Epithelioid hemangioendothelioma, TFE3 is the IHC marker that will show expression in cases of epithelioid hemangioendotheliomas. MPNST H3K27 is loss of H3K27 is what is being recognized in cases of MPNST, and if you see absence of expression of these marker, nuclear expression, then you can diagnose these cases as a MPNST. For CIC rearranged small round cell tumor, WT1 and ETV4 are the two markers which will show you nuclear positivity. Sarcoma with B-cord genetic alteration, they will show you diffuse nuclear positivity with B-cord IHC, and epithelioid MPNST, there is a loss of INI1 by IHC. So these are the newer markers which could be extrapolated in the diagnosis of these soft tissue tumors. Now, other thing that has come up for the prognostication of the tumor, and the most important prognostication of the tumor has come up in the solitary fibrous tumor, because their rate of recurrence and their rate of metastasis have not been so well described in the previous classification. So now they have given a risk stratification of solitary fibrous tumor, and based on these four modules, that is what is the age of the patient, the size of the tumor, the mitotic count, tumor necrosis. Now in this particular case also, you see that in a solitary fibrous tumor, if the mitotic count is more than 4 per 10 high power field, that is a very strong risk category for metastasis. So if in a solitary fibrous tumor your mitotic count is more than 4, it is not 10 over here, even if it is 4 mitosis which you are seeing per 10 high power field, then the chances of the SFT which can undergo metastasis or recurrence are very, very high. And then other features which are also classified in the risk stratification for solitary fibrous tumors are the size of the tumor. So larger the size of tumor, the greater chances of recurrence and metastasis, and similarly for necrosis, less than or equal to 10%. So this risk stratification has been recently described, and why so much development has come in SFTs is because the nature is very unpredictable. It was not clear which of these tumors are going to recur and which of these tumors are going to metastasize. So that is why this risk stratification has come up for SFTs, and now we have a new marker for SFTs also, and that is STAT6. So with this, we wind up this extensive chapter of soft tissue pathology. So the points to be remembered here are, so I would say the soft tissue tumors can be benign, intermediate and malignant, as we have seen. Intermediate, if they put their throngs on into the surrounding soft tissue and it is difficult to resect them, if they have chances of recurrence after resection, then we call them as intermediate. Whereas the tumors which are florid malignant, that is they show atypia, they show mitosis and they show necrosis, then those are the ones that we call them as malignant. Try to make histological histological diagnosis with the nature of cells and the pattern. So you have to see whether the spindle cells are going to have a eosinophilic cytoplasm, whether the spindle cells are showing waving or buckling of the nuclei, whether the spindle cells are showing you a biphasic pattern. So based on your histological findings, you are going to say that your tumor is a leiomyosarcoma, it is a neural tumor, or it is a synovial sarcoma or others. Look at the periphery of the lesion. So whenever you're getting any soft tissue resection specimen, most important thing is the location, whether your tumor is located superficially or deep, and then you are going to see the periphery of the lesion. So capsule of the lesion is going to be very important. If the lesion is well defined, if it is well circumscribed, or it is pushing its throngs into the adjacent tissue, then you say that this is intermediate. Mitosis is not the only criteria of malignancies, and we have certain soft tissue tumors which are relatively high mitotic rate, like you have cellular schwannomas, mitotically active schwannomas, ancient schwannomas. So those, they show you high mitotic rate. So it is not just the only criteria of malignancy. And necrosis, if you see in a soft tissue tumor, it is definitely bad unless it is a pseudosarcomatous lesion like ischemic fasciitis, where you do see some necrosis. Sarcomas in the young, if you are seeing sarcomas in a younger age group, so most sarcomas will come to you after 50 years of age, but if you're seeing sarcomas in a younger age group, then these are the sarcomas, generally sarcomas of uncertain differentiation, and you should think of synovial sarcomas, epithelioid clear cell, and mesenchymal chondrosarcomas as one of the differentials. So with this, we end this session here. Thank you so much for your patient hearing. I know it has been an extensive topic, and I thought we'll discuss one case, but then in the end, I realized that it is composed of so many varied populations. So we'll discuss the type of the tumor then. So thank you so much. I hope it was made a little bit simpler and easier for all of you. Thanks once again.